Great. We might as well get started. My name is Jeff Wong. I'm a spine surgeon in Los Angeles, California. I'm the immediate past president of the North American Spine Society, and I just want to welcome all of you to the webinar. In this webinar, we're going to be talking about a few things. We're going to talk about part one, which is really just an update from around the world and also from around the United States on the current status of different countries and different cities. And then part two is really going to focus on recovery. I'm sure you've all seen a lot of webinars on, indications for surgery, what we're doing now, but I think we need to look ahead and look at what recovery looks like. And so I think the second part will hopefully be quite interesting. We explore when it's time to resume and at what point we can start to get back to a little bit normal. I want to first start by thanking the North American Spine Society for giving us the platform to do this broadcast. As a disclaimer, we're not an official government agency, and the opinions you're hearing today are really the opinions of spine practitioners from around the world. They don't represent the opinions of any government agency or anything like that, so it's really just our opinions. I'd also like to mention that at spine.org, which is the NAS website, there's a collection of resources for any practitioner, and you're welcome to take a look at it. It's kind of a collection of resources, financial resources, clinical resources, kind of putting together all the current information on the COVID-19 crisis. I want to thank our speakers for agreeing to speak today. We have speakers from around the world, especially those in countries where it's pretty late or it's in the middle of the night. I really want to thank you for taking the time out, and for those across the country from your busy schedule to participate. A couple ground rules. I'm going to ask every one of the speakers to mute themselves because if there's any stray noises that can interfere with the broadcast. When I call on you to talk, we'll certainly give you time to unmute to give your opinions on things. I'd like to just introduce everyone as a group, and then we'll start with the talks. And when you are going to talk, maybe you can give a brief introduction of yourself if I didn't give you the appropriate introduction. But I want to thank Professor Yang Hai from China, Professor Yoon Ha from Korea, Professor Gabriel Liu from Singapore, Professor Hani Milhagli from Spain, Juan Emmerich from Argentina, Carsten Wiechert from Germany, and then from the United States, I want to thank Roger Hartle from New York City, Jens Chapman from Seattle, and Serena Hu from the Bay Area, and Patrick Shea from Los Angeles. So what I'd like to do is just start with an update from around the world. If you're international, I'd like to hear what's going on in your country as well as what's going on in your city. If you're from the United States, and obviously a lot of us are from the States, we just kind of want to hear what's going on in your city. And what I'd like you to do is answer 5 questions, and you have about 3 minutes to do so. The current state of cases and the social situation in your country and your city. What is the current status of your hospital? Are you doing elective cases or only emergency cases? How this has affected your hospital, university, or the public financially, and what you're doing for resident and fellow education. And if you forget any of those questions, I'm happy to remind you of that. So with that, let's start internationally, and we'll start with Professor Yang Hai from Beijing, China. Professor Hai, can you give us an update?
Hi, Jeff. Hi, everyone. Greeting from Beijing, China. Nice to see all of good old friends. And in China, right now we have the active cases is less than 3,000. And normally, right now, every day we don't see that much case diagnosis within China. In Beijing, we have not have any new case for the last 20 days, just only several cases from the people they come back from overseas. And most of the China, they are pretty open back to the normal. For Wuhan and Hubei, they are just opened 1 week ago. And for Beijing, our
Professor Hai, I've kind of lost his audio. Does anyone else hear him? Professor Hai, we've lost your audio for now. So at this point, if you can work on that, we may want to go, let's go to Korea. We'll go to Professor Yoon Ha. Professor Ha, why don't you give us an update of what's going on in your city, and maybe once we can get Dr. Young Hai back. So Professor Ha, you need to unmute yourself. Professor Ha? Yeah, you're still on mute. I think we're having some technical difficulties. Gabriel, why don't we get an update from Singapore while we're trying to get a hold? Oh, Professor Ha.
Oh, can you hear? Oh, can you hear me?
Now we can hear you. So why don't you start over? Why don't you introduce yourself and give us an update?
Okay. Good morning, everyone. I'm Yoon Ha from South Korea. I'm currently working in Yonsei University Hospital. Regarding the current status of Korea, today we have.
And also we have a special isolate.
Why don't we go ahead, Professor Ha, why don't you talk? And in the meantime, I'm going to try and get a message to Dr. Hai.
Okay. Yeah, so our Korean CDC today officially announced that the total number of confirmed cases is 10,591. But our daily new case is 27 today. It's dramatically decreased the number of new cases. Also, new deaths today is only 3. And the first case was outbreak in January 20. And we have a big outbreak in March 12, about 1 month ago. And there was a big explosion, especially in southeast part of Korean Peninsula. But Seoul is a relatively safe place. But now we have decreased the number of sporadic community cases, but increased the number from overseas country. So can I talk more about the current state of a city socially and
Sure.
the hospital strategy, something like that?
Yeah, please.
Okay. So regarding the current state of the city social life, the few months ago when COVID outbreak in Korea, Korean government decided a legal restriction for accomplishing the disease eradication. These are social distancing, personal hygiene, such as frequent hand washing, wearing facial masks, using hand sanitizers. Also, indoor sports activities, clubs, bars are suggested to close temporarily, especially in high-risk cities. Now, in Seoul, our municipal governor strongly prohibit especially in nightlife activities. But we do not perform the lockdown policies yet.
Okay.
Regarding the current status of our hospital and my surgical practice, fortunately, I do surgery as like before COVID-19 outbreak. When we had a big outbreak 1 month ago, hospital board asked for reducing the surgical volume for reserving the space for corona patients. My surgery volume is slightly lower at the time, but I do not attend the conference and the international meeting. Therefore, total number of surgery is higher than the same period of the time last year compared to last year. The hospital and my nurse practitioners screen the patient who have a high risk of corona infection, such as a history of a high fever, runny nose, sore throat, visiting endemic area, and so on. And when patient admit to hospital for surgery, we routinely perform corona RT-PCR test. Also, our hospital treat corona patients. In order to keep the safety, we have totally separate system, such as different building, different ICU, different lab and management team. So therefore, we do manage the patient with coronavirus or without coronavirus, totally separate system. And regarding the financial issues in the hospital, my hospital is a tertiary referral hospital. Most of the patients are critically ill. Therefore, the number of visiting patients are not so much decreased than expected. So I haven't been informed that our hospital has a big noticeable financial issues. The resident training, we have stopped doing a regular spine conference, but we are doing a weekly Zoom-based Zoom tele case conference instead. Yeah. So now we are going back to daily normal surgical life, but still we are very concerning about the visiting the corona outbreak, because if we opened our society, the corona patient will have a much better, much higher numbers. We have a very painful experience 1 month ago. Thank you.
Okay, thank you. Gabriel, why don't you give us an update what's going on in Singapore?
Sure. Right. Hello, everyone. In Singapore, currently, we are quite lucky in the beginning of the start in February. Based on the contact tracing, isolation of the patient, we are able to contain the outspread, the outbreak quite fortunately. But unfortunately, until the middle portion of late February, early March, we have a second wave of attacks. So what happened is that currently, what we are having, we're experiencing a high load of daily cases of COVID-19, isolating from a second wave of attack from some of the known cluster. For example, on Sunday, we have over about 200 cases, and of Monday and Tuesday, 300 cases. And then today, just now, the latest figure, we have over 447 cases, and bringing our cases to all of a sudden to about 3,699 cases. Luckily, what happened is that we only have 10 deaths at this point of time. Mostly are at-risk patients, elderly patients, 70, 80 years old with multiple comorbidity. So what comes about with the second outbreak is really isolated from the a particular sector of people. They are some of our construction worker from overseas hired by company. So when they finish the work, what happened is that they all go back to the dormitory to sleep. So there was one worker who have contracted the disease from a shopping mall, bring it back to the dormitory, which housed almost 7,000 workers. And with that cluster, in the last 2.5 weeks, we have an outburst of the second wave attack as we described early on. Currently, what we're doing with them is that we're still isolating them, separate from different dormitory, sending in on our medical team to stabilize them and to monitor them. Hopefully that they will not require any ICU stay or more. In regards to this city, because of the sudden second wave of attack, and then we are now working for almost like treating it like a community spread. So every Singaporean by law have to go out with a face mask, and the government have actually given every single Singaporean a cotton face mask. Then we have no excuse not to wear one. And then the second thing is that all the non-essential services have been switched off. So only about 20% of essential services have remained. And all the parks, all the eateries is closed. And we are allowed to go to markets to buy essential food and to buy takeout. Other than that, most of the services are currently it's what we call it a circuit break, or similar to a lockout, and we are starting the first week of that. The government has tried to stimulate the business, and then we have so far have 3 stimulation package, and the total amount of money is about 59.9 billion Singapore dollar, and it's about 12% of the GPT for Singapore. And then we were hoping that within this month we can still hold the economy, and therefore the strategy is still not completely shut up everything, because Singapore is a 5 million population. If you completely shut everything, then there's a lot of problems. For example, currently there's a big crisis in Singapore Airlines. All of a sudden they need to raise a huge amount of money in order for them to survive, and that is just the Singapore Airlines alone in that respect. In regards to the hospital, and then the way that we deal with it, and since early February, what happened is that in order to retain, to balance our resources, we have already stopped all our elective surgeries. And then in March, and then in the later March, as the outbreak start, that there's no day surgery, i.e. you can't do the surgery, let's say a discectomy that the patient leave the same day is no longer allowed. And currently, we only allowed to do emergency surgery, which is basically fracture, infection, cancer, or severe neurological deficit. In terms of the team-wise, most of our doctors are separated into two teams, and they don't meet each other. And because of the severe outbreak now, in terms of we will only isolate one doctor to do ward clinic duties, and one doctor separate just to do the ward and OT services, and the rest of the doctor will remain as standby to be deployed to other services, and yet at the same time don't meet each other. In terms of training wise, and then as per Professor Ha was talking about, we stop all the meetings. We are not allowed to meet each other team in the same division, and of course we are not allowed to meet different hospital doctors. And most of us are relying on websites, Zoom-based, and we have started our basic residency training and also our audit system through this as well. So this is the status for Singapore at this point of time.
Great, thank you. Hani, let's go to you. What's it like in Spain right now? Hani, you're still muted. Can you unmute yourself? There.
Now? Okay, sorry. Thank you, Jeff. I'm Hani Maidli from Spain, spine surgeon, president of Iberian and Latin American Spine Societies. Unfortunately, Spain now is the most affected by the coronavirus country in Europe. Spain now ranks the second in the world behind the United States. And the updated number confirmed cases in Spain now 177,000 cases. That makes 10.5% worldwide reported cases. It's a lot. But we're observing a drop in new coronavirus cases. The number of deceased is to 18,500 cases with 520 deaths in the past 24 hours. That makes the third highest death toll from the new coronavirus. First, United States, second, Italy, and then Spain. We are not happy with the numbers, but we are happy with the curves. The curve for infection has been flattening, and now we already passed the peak, and hopefully we are going down. That made the government to ease a little bit the lockdown, but we are still in the state of emergency. Some factory and construction workers returned to work on Monday. And masks in public transportation is mandatory. So if you go to the subway or to the public bus, you have you need to have the mask. School and colleges are still, as well as colleges, are closed. And we believe that the general confinement will remain as a rule for the next 2 weeks. About the hospitals, as you know, the system, we have a public system in Europe, Spain also. We have public hospitals and private clinics. But Spain has put all private hospitals under the government control. So all have very strong economic and social consequences. Regarding the education and fellows, there is no doubt that the coronavirus pandemic has affected the education system worldwide. So many residents and doctors and fellows are helping at emergency and where they are needed. So the Spanish doctors are scared and exhausted by the pandemic. We are not really education, and for the fellows and for the residents, it is not really now in a good shape. So we are now out of the peak of the curve. We are improving, but the numbers are too high. We should not be happy when having 500 deaths per day. So we hopefully we start thinking, we see the light at the end of the tunnel at the end of the month.
Great, great. Thank you very much. Juan, why don't you give us an update what's going on in Argentina?
Hi, hi, thank you, Jeff, and thank you, everybody. You know, here is a total different situation. We are just starting. We are waiting for the peak. We right now have around 2,200 cases. Probably we are understated. We are not really making all the tests we need. We are under testing the population, but the death is less than 110. Right now we have 108 persons. That means we are very far away from our peak. And this is a totally different scenario. You know, I believe probably for the first time in our history, we are doing the things in the right way. The government and the population are taking this really, really seriously. We have a full lockdown for around 1 month. Of course, it's a huge problem in the economical point of view, but was a really game change. We start to have cases around 1 month, 4 weeks ago. And until now, things are doing really well in the public health system. We have plenty of space in our hospitals. ICU are really empty. You know, we have less than, I believe, 50 patients in ICU, and we have a total available for around 5,000. So that means we are really empty. And that is a challenge as well, because we don't know how much time we can continue this way, you know, because of course it's absolutely a good election and a good option, but the economy is really, really hard right now, and people are extremely, extremely worried about these things. Regarding our daily practice, we are still doing cases. We postpone or not, you know, really urgent or semi-urgent cases, if you can call, but yesterday I treated a big brain tumor. And of course, we don't have too much trauma, but we are doing a lot of spine surgery, especially, of course, tumors, but some patients with not so urgent cases. You know, we cervical pathology, we are treating a lot. And of course, our anesthesiologists are really worried about the intubation and other things, but we are still doing very well. We are in absolutely closed. All the business are closed. All the schools are closed. People are wearing masks in publics. But with any doubt, the biggest concern we have right now is how much time we continue this way. You know, it's quite like, you know, paradoxical, because in some way we are doing really good. You know, we are saving a lot of life, but this scenario can continue too much far away. And Argentina it's quite different to the rest of Latin America. And I take just 1 second to talk for the big picture here. The big problem here in Latin America is the poverty. We have a lack of resources. This is totally different from Asia Pacific and North America. And here the big challenge is how we are going to deal with poor health systems and the poor population generally. And that will be the big challenge, and everybody's worried about that. We are waiting for this. Brazil was the big country, the big and the first country is dealing with huge problems. Right now they have 200 deaths per day, and it's a totally different scenario. But here, Jeff, things are doing right. We want to learn, and we learn from Asia Pacific, and we want to learn from North America, because right now the best vaccine we have is information, and this kind of meeting are extremely important to share knowledge and learn from the best. And with any doubt, you are the best. Thank you, Jeff.
Great, thanks, Juan. Karsten, why don't you give us an update what's going on in Germany?
Well, in Germany, we also have a lot of cases. We have 132,000 cases and about 3,500 new cases per day, which is much lower than what we used to have. And the proliferation time is about 16 days right now. We have had a remarkably low number of deaths so far, about 3,500, which is great, and there are a number of factors contributing to that, and this will probably most likely rise in the future. Germany, which is a town of about 1.5 million people, we have 4,800 cases, out of which 2,000 are active cases. We have 600 hospitalized patients, and the statistics show that we have 147 patients on ventilators and 158 still ventilator capacity for COVID only patients. So we have between 100 and 120 new cases a day. So it's a fairly stable situation, and it's decreasing. Regarding our hospital, it's an orthopedic only hospital, and we actually joined up with a general surgery type place and with an internal medicine hospital. So the three hospitals are basically counted as one. We helped them with the staff. We helped the internal medicine people with ventilators and so forth. So their capacities and knowledge, obviously, in treating this disease, is much higher than at a purely orthopedic place like we do. So far, we've canceled all elective stuff and doing only some trauma and some which is rather emergent. However, this week we started doing elective surgery again. Our outpatients clinics are starting to run again, and we're trying to get back to sort of normal as the circumstances given. Residence training is basically on hold right now. We don't have any formal conferences or anything like that regarding teaching. The whole situation in the city is that everything is on lockdown. Schools are closed, kindergartens are closed, and everything. Some businesses are open, but whoever can does home office type things. The public discussion about when to reopen the economy and the entire economic impact is here as it is in every other country. You have to wear a mask when you go in public places, when you use public transportations and so forth, which is very unusual for Europeans to do so. About half of our staff at the hospital actually is in government-funded temporary leave because when you don't see these patients and when you only do non-elective cases, you just need less people. So this situation is partially subsidized by the government and by the company that owns the hospital. So there are no economic hardships for the doctors in this situation.
Great, thank you. Let's start going around the United States now. Roger, I know New York has been hit very hard. Why don't you give us an update of what's going on in New York City?
Yeah, thank you so much, Jeff, for having me here. And it's fascinating to hear these blinks from around the world. My name is Roger Hartle. I'm a neurosurgeon at New York Presbyterian Hospital, Weill Cornell, and the chief of spinal surgery at Weill Cornell. And as you know, New York has been hit pretty hard, as many other places have. But currently, we have about 200,000 confirmed cases in New York State, and half of these cases are in New York City. The total mortality is about 11,000, most of those in the city. And as Governor Cuomo mentioned yesterday, I think, we're at the level of, we're plateauing. And it has been like that now for a number of days, and it looks pretty sustainable. If you look at New York Presbyterian, which is one of the largest hospital groups in the state, we have about 9 hospitals, and I have the numbers of patients that are being treated at New York Presbyterian, and I think we take care of about 70% of the patients. 2,400 patients admitted in the hospital COVID positive, and about 760 patients intubated, which is an incredible number, as you can imagine. Now, keep in mind that we have many other hospitals, of course, in New York City. We have capacity from US Comfort, which is a ship that docked here a few weeks ago that's taking care of non-COVID patients, but now I think also of some COVID patients. We have additional hospital capacity in Central Park, where they put up tent hospitals that are partially filled with patients now. And then one of the biggest conference centers in the city, the Javits Center, has been converted to a hospital with thousands of hospital beds. Fortunately, as I mentioned, it looks like the numbers are now plateauing. As it pertains to our surgical program in the hospital, it's been very, very dramatic to watch the changes. We have about 40 operating rooms. The majority of these operating rooms have been converted to ICUs and are currently filled with patients on ventilators. We still have a few operating rooms running for emergency cases. And as some of the speakers before mentioned, we can do emergency cases, but these cases have to be approved by a committee of surgeons who determine that these cases are really necessary. For us, that means there's a progressive neurological deficit. Some of the operating rooms have been reconstructed. And this was done within a few days. They constructed negative pressure rooms, and they implemented ante rooms where patients are actually being intubated outside and then brought into the operating room intubated to minimize the risk of infection to the operating room staff. So, and this looks like it's going to go on for a few more weeks. We've slowly started talking about how to progress into recovery phase where we can start doing more elective surgery, but we're just at the very beginning and we're trying to explore that within the hospital. It is amazing to see across the city how all the hospitals are in the same boat. We have so many different hospitals, and initially there was talk about, maybe shifting patients from one hospital to the other, but at the end of the day, that was all shut down, and every hospital is really in the same situation, which creates a certain feeling of solidarity. I think it's actually quite good, but it'll be interesting to see how we go back to normalcy. In terms of patient visits, we use telemedicine now much more. Every one of us, and we see new patients and follow-ups with telemedicine, which actually has been quite remarkable. And it's one of those things I think it's going to stay on. It's going to really help us coming back into business. And then in terms of resident education, again, it's Zoom conferences, WebEx conferences, Skype calls. We have conferences for residents on a daily basis, and we do case conferences, journal club, research conferences in the campus, but also across campuses. And the residents, it's really all hands on deck. A lot of them are deployed in the ICUs. We have, I think, 16 residents. 10 of those residents are deployed. So it's quite remarkable. Everybody is really working together. The one good thing is Central Park. I don't know if you've been to New York, but Central Park is still there. And you can go to Central Park, you can go running, you can exercise, you can walk around, and people take advantage of that. And that's the one positive thing to report. And fortunately, that has not been curtailed. And hopefully we'll continue to provide some, recreational function. And I think that's in a few minutes, an update on New York.
Great, thanks, Roger. Jens, why don't you give us an update what's going on in Seattle?
Good morning, everybody. Can you hear me okay? I hope so, thanks. So we have the dubious distinction of having been the first US city to have been hit with COVID. And we're also very happy to have the curve flattened. I don't know whether this projects, but this is, despite increased testing, a brief curve of cases in our state. So the number of cases has decreased dramatically. Same for the number of deaths was dramatically decreased. In our hospital system, there's still a complete lockdown of all hospitals. So it's like a military compound almost. It's a surreal scene. We get a lot of very sick patients in our system, and over half of our beds are empty. And in our ICUs, which have ECMO capacity, we're one of the few hospitals for ECMO places. We have only a third of our ICUs actually filled. Our ECMOs have been very successful, I'm happy to say, thanks to our great cardiothoracic surgeons. That's an interesting physiologic insight in what actually goes on in these diseases. In terms of our cases against spine, this incredible in-between specialty, we have an elective component. Obviously, we have a urgent and emergent component, and then there's a large number of patients that are somewhere in between. So we've very rapidly gone into telemedicine, and again, today I'm going to see about 15 patients, but whereas I usually do about 10 cases a week, I'm right now down to maybe about 2 or 3 cases a week. And only after a very bitter debate with our selection committee. So this is something that I think will be an interesting debate point as to where what spine care should be rendered. The curve flattening has been so encouraging that now there's another bitter battle brewing, that is when and where and how do we restart things. So we will clearly come out of this with more teamwork and far more kind of triage and guidelines as to what really matters and what resources are we consuming and what is the turnaround in terms of getting patients back to their lives. The efficiency of our operating rooms has been obviously severely diminished. I'm not going to replicate what previous speakers said, but the just room turnaround times are going to be forever probably different. In terms of teaching, again, we have a great privilege of SSFTD. Last night we had an interesting case debate with Texas Back Institute and Rothman Institute, and we had, I think, 2,600 live visitors. So that's been a daily conferences like what Roger's doing. Our fellows have been engaged very heavily in conferencing around the country, just like this wonderful event that you're hosting, Jeff and Nat. Thank you very much. I think we'll be far more connected in the future and make interdisciplinary events also far more feasible. So that's my update from Seattle. Thank you.
Great, thanks, Jens. Serena, why don't you give us an update on what's going on in the Bay Area? Serena, you're still muted. Serena, you're still muted.
Can you hear me now?
Yeah.
Can you hear me? Okay, I can't hear myself, but that's okay. So as some of you may know, California was the first state to kind of go into the shelter in place. And not only that, San Francisco itself declared a state of emergency about 10 days before that. So we've been shelter in place since the 16th of March. At UCSF, where I used to work, they stopped doing elective surgery on the 6th of March, and Stanford, where I am now, stopped on the 13th. We have also managed to flatten the curve quite significantly, it's really, we've been very fortunate in that, but because of that, we've got a lot of empty beds in our hospitals. The number of elective cases is essentially nil. We had 20 cases at UCSF last week, 17 at Stanford this week who were COVID positive. At Stanford, half of those were in the ICU. So there are very, very sick patients, as Roger alluded to. Stanford only screens patients for the urgent cases if they have symptoms or exposures. UCSF tests all of their surgery patients. We do have an antibody test available now at Stanford. They started it on Monday. Takes a couple days for results, but they're only testing about up to 500 per day. So it's still very slow to get off. But hopefully that'll help us from the standpoint of as we go back online to determine who's been exposed and who might potentially have immunity. As with everybody else, we've been doing video visits. The few patients we see in person are screened as everybody who comes into the hospital. That seems to be working very well. And as Jens talked about, that's going to be, I think, the wave of the future from the standpoint of connectivity and being able to offer that to our patients. Obviously, this has really affected our resident education. So we've gone to teams for the residents. They have a week on and then 2 weeks off to maintain quarantine and separation, and then an attending rounds each week. And I happen to be the attending this week, rounding with the residents, which is kind of an interesting experience. Lots of trauma, interestingly enough, even though there aren't a lot of people out there, they seem to be driving really fast when they get out there. So we've had a few multiple traumas coming in that are keeping the trauma people busy. For education, we started going back to just basically doing all of our regular grand rounds, which I'm supposed to be on now, via Zoom, and as well as doing our M&M. It's actually worked surprisingly well, and people have adapted. And we also, each service has an hour a week designated that we can teach the residents that we do on a rotating basis, which keeps the residents connected and keeping the activities active. Other services have different things, but I've been basically meeting with the residents after my clinics to talk about an interesting case for an extra, half an hour, 20 minutes and half an hour for teaching each week. So basically, we've been lucky from the standpoint of cases up in the Bay Area here, but probably at a significant, at least economic and elective care cost, and it'll remain to be seen how that pans out as we go back. Gavin Newsom, our governor, Patrick may talk about this also, has talked about the phase-in plan for California and how that's going to happen, although we don't have a timetable yet. Thank you.
Great, thanks, Serena. And lastly, Patrick, why don't you give us an update of what's going on in Los Angeles?
Great, thank you, Jeff. I hope you can all hear me. Greetings from Los Angeles to all the friends and colleagues internationally. I think obviously this is a tough time for all of us. Fortunately in Los Angeles, we've been pretty lucky with our cases of COVID. Serena's touched upon this. We've been fortunate for a number of issues. Number one, the shelter in place was implemented very early. I think unlike New York, we also benefit from a lesser population density, even though we have the second most populous region in the U.S. So currently in Los Angeles, we have about a little over 10,000 cases in Los Angeles County. I think that we have about 350 or 360 deaths thus far. The highest rise in death cases was reported yesterday at 40, so a much smaller number than many of the areas we've seen in the U.S. as well as outside the U.S. internationally. From a social standpoint, it's quite eerie to see what Los Angeles is today. I mean, we have much less pollution and traffic. In fact, the quality of air has not been this good since the 1980s by reports. People are generally out with their masks now. Even though it's not officially mandated, most people are out with some type of mask protection. The beaches and the public parks are closed, and only really essential workers are out there, and I think the majority of people are confined close to their home and to their essential activities. In terms of its impact to our hospital system, we have 3 main hospitals in our hospital system. Our spine center is located in the Keck Medical Center, which does not have an emergency room. So you can imagine that for the most part, our case volume and patient volume have dropped tremendously at our main medical center. Most of us are doing telemedicine consults for our follow-up and post-ops. Really, we're seeing some new patients if they're deemed to be potentially urgent or emergent that may need to go to the operating room. These patients will need to be screened for COVID before they get into the medical center and get into an OR, and they will need some type of clearance from our medical staff in order to be scheduled and proceed. But in our 2 other hospitals, we're generally doing more elective and more trauma cases and less elective cases in those hospitals as well, but they have emergency rooms, so we're taking mostly COVID patients from the county side. I think that in terms of ramp up, Serena's touched upon this. There's going to be inputs from the federal government, the state government, as well as even our local city government, and all the indications points out that even though we're plateauing, we really expect that this curve's to be dragged out much longer, probably well into June potentially. So at this time, I think that most people are realistically targeting mid-May before we truly get back to some open return to our work and activities. But even that could be changed, and it's quite a dynamic process at this point. The governor of California did lay out 6 criteria, and I think that for the most part, I think the criteria are likely achievable in the coming weeks in terms of the ability to test and the ability to make sure that we have enough ICU resources and ventilators and PPEs and et cetera to take care of the expected cases that are in the plateau phase, if you will. So I think that we still have a lot to figure out and learn from this, and hopefully we will get back to our relatively normal lifestyle in the next 4 to 6 weeks.
Great. Well, thank you for that update. And now I think I'd like to go into phase 2 of this webinar and talk about what recovery looks like, because I think a lot of us are wondering, when do we restart, and when was that point we're going to reach that point? And so I'd like to ask a question for those people that are starting to do elective cases, that are getting a little bit back to normal, what that looks like. And so my first question will be Professor Yang Hai from Beijing. If you can unmute yourself, Professor Hai, and tell us in China, when was it time to restart elective cases? Was it when the government told you you could do it? Was it when you saw the cases dropping? Or we just want to know at what point we can look forward to starting.
In Beijing or in China, normally it's the government will lower the emergency response. And in that period, most of the cities are in the level 1 response, so there's no elective surgery. But now is almost all the cities are back to the level 2, except in Beijing. So in Beijing, we the hospital and the government were saying we are gradually back to normal for the normal clinic and the normal hospitalization. But with every patient has to be in Beijing for 2 weeks and test the PCR negative, and also chest X-ray, CT scan are normal. Then we'll go just back to the normal procedure. And because about 3 weeks ago, the Beijing airport has been closed to all the foreign airline, so we don't have that much cases. And all the patients they have elective surgery has to be test negative. In Beijing, we don't accept the patient from out of the Beijing yet. The central government just afraid there will be some the second wave of the patients. And for the other city, for example, the big city like Shanghai, they pretty back to normal, 70-80%, and with no or very few local cases, and they're pretty back to the normal procedure. So that's the condition right now in Beijing. Great. And in most of the area of China. Wuhan, they opened up last week to the back to the normal selective cases, but has very tight screening of the patient. Once they are positive, they will have a special hospital, designated hospital and the OR for dealing those patients. Thank you.
Great, thank you. And now let's hear from Korea. Professor Yoon Ha, you said you're back to doing some cases. At what point did you start doing those cases? Was it when the government told you, or when you saw the cases dropping? And then which cases did you start doing? Did you prioritize the younger patients, the one that are COVID negative, or did you prioritize based on urgency? Oh, and please unmute yourself. We still can't hear you. We can't hear you, Professor Ha. We'll come back to you maybe. Karsten, let's go to you. You say that you're starting to do cases. So tell us, at what point were you allowed to do cases? Was it when the curve was dropping, or only when the government told you? And then how are you prioritizing those cases? And we're getting a lot of questions on testing. Do you make sure that you test all the patients and make sure that they're negative?
No, we don't test all patients, but we screen them, and in a way, and if they have any type of contact, or if they have any type of history in this regard, they're not admitted in the first place. Now we screen them, or we select the elective cases one on urgency. I mean, those who have a neurological issue, those who have a stability issues, stuff like that. But we also try to make sure that we use up as little ICU resources as possible. So those who might need prolonged ventilation, those who might need a night on the ICU, or those who might need blood units, they don't get their surgery at this point. With very, very few exceptions, like in some tumor cases we had done throughout. But otherwise, I mean, no, we're not doing the 95-year-old spinal stenosis case at this point, obviously, but we have the feeling we're not helping anyone either if we do not do, let's say, sequestrated disc surgery with patients in massive pain at this point. I mean, they can be done as a one night or outpatient type of procedure, and so the risk there is fairly limited. Now, we were basically allowed to do this when we found that cases were decreasing, or that they were plateauing in a way. The situation in Munich is fairly stable, so we don't run the risk of running out of medical resources anytime soon at this point. However, we are expecting a second wave in terms of cases and in terms of death when all the retirement homes and all the geriatric places come into play, because there are a lot of those institutions that report positive corona cases right now, and this might change over the next week or 10 days from now.
Okay, great, thank you. And now let's go back to Professor Yoon Ha in Korea. Again, when did you start redoing your elective cases? At what point, and how are you prioritizing those cases?
Actually, a few weeks ago, we have a big outbreak in southeast part of Korea. So at the time, our hospital board suggests reducing the volume of surgery, but not formally stop doing surgery. So I still did surgery in those periods, but the number of surgery is less than before. But now we are getting, our situation is getting better. So I do surgery as like before corona outbreak. So there's no prioritizing principle. There are no triage strategy for screening, prioritizing the patient selection. But still we have sporadic corona virus cases in Seoul. So we routinely screen the corona questionnaire, such as runny nose, high fever, things like that. And also we routinely perform the coronavirus RT-PCR test in every surgical patient. So things are getting better, but we are very concerning the second wave of attack, because next week our government lose the social distancing policy, but as like other countries, probably we will have a more new second wave cases. At the time, we maybe change our surgical strategy. Thanks.
I'm sorry, you said your Korea is going to relax the social restriction distancing policies?
In this week, we will, if we have less numbers, still we have around 30 cases of the corona patients in daily basis. So if we the number of new cases less than 20 or 10, our government will lose the social distancing policy, such as the opening the school and opening the some nightlife the facilities and indoor sports activities, things like that. But in hospital, we still keep the social distancing.
Okay. And Jens, let me put this question to you. Obviously, in the United States, we're still kind of dealing with just our urgent cases only. At what point do you think, if you can project out, when can we start getting back to elective cases? What are we going to need to see? You're a pretty thoughtful guy, and you had those curves on your phone. At what point do you think we're going to be able to start seeing patients and doing elective cases?
The pressure is immense to restart. Our hospital system loses roughly $1 million to $2 million a day. So they want to get back into regular working mode. What we're basically seeing is that we have to have a balance between invasiveness of the procedures, the risk magnitude resulting from that in part, and the patient's morbidity, and the acuity index. So the test will be over the next 2 weeks. We're going to do less invasive surgeries that have a predictably short hospital stay to keep patients out of the hospital and as short in the ICU as possible. I foresee far more staged surgeries being done, for instance, posterior reconstructions and bring the patient back for a secondary anterior procedure or vice versa, depending on the clinical situation. But as the next 2 weeks come in, we're getting into this intermediate phase, and we're creating new councils that more or less try to arbitrate in these contentious situations. Thank you.
Great, thanks, Jens. And Roger, I don't know if you're still on. I don't see your face. If you can hear me, yeah. Roger, obviously New York's been hit the hardest. What did you guys see in terms of redeployment of spine practitioners, whether it's your spine residents and fellows, the spine surgeons themselves, or like the injectionists and the physiatrists and the pain management folks? Obviously, New York's been hardest.
You know, it's really, it's most hands on deck. 2/3 of the residents have been deployed to various departments. 2 of our 5 spine surgeons are in the emergency room taking care of patients now. And then I know from across the different hospital sites in the city that it's very much the same. A lot of my colleagues who are sometimes very experienced and very busy spine surgeons, you know, do shifts in the ICU or in the emergency room, and that's still ongoing. So that hasn't really changed. They don't recruit any new physicians now. They're pretty much at a level where they can live with the number of doctors, but they're still using them.
Great, thank you. All right, so I'm going to take some questions here. So first question is actually for Serena. Serena, for asymptomatic patients who test positive with the antibody kits, are nasal swabs needed to determine if they are still active secretors of COVID-19 virus?
No, I believe that they're still testing people for when they stop secreting the virus for the communicability issues. So we have a resident who tested positive, and they initially said he could go back to work after he was asymptomatic for I think it was 5 days, but then they changed their mind and decided he needed to have a negative test. So that is the recommendation on this side of the country.
Okay, thanks. Patrick, a question from the audience. How much can you wait for myelopathy cases? What is the criteria for doing surgery on these patients with cervical myelopathy?
That's a great question. That's actually a problem that I'm currently struggling with some of my patients. I think that, you know, the fortunate thing for most cervical myelopathy patients is that the natural history is a more gradual stepwise deterioration. So I think generally, I think you have a couple, you know, you have several weeks and maybe even a couple months to make sure that we get it into a safe environment. I think that patients who are clearly having rapid and progressive neurological decline should be treated essentially as an urgent emergency cases. Now, those patients probably won't need to go into the operating emergently without getting COVID testing. I think they'll still get COVID testing to make sure that they're at least getting appropriate precautions for, but those patients should be getting into the operating as soon as possible. So, personally, it's one of the reasons why I keep up with the telemedicine to make sure that my patients seems to be relatively stable in terms of their neurological symptom not progressing. And if they are, I think that we need to continue to advocate for those patients to get them into the operating room.
Great, thank you. Hi, there's a question here. When elective cases are started back up, are surgeons or OR staff using N95 masks, or is there any specific protocol? So what's your protocol when you're taking care of, you're actually doing the surgeries? Any special precautions? And please unmute yourself. Hani, you need to unmute yourself. There you go.
Good, great question. So in our hospital, we are separated from the coronavirus patients, so it's maybe it's a bit easier. So we try to have only for the anesthesia, only the patient with the anesthesiologist alone will be. By this way, we can avoid the contamination. We use the N95. And we use all the other stuff that was mentioned before. I mean, the special protection, double gloves, and we try. Even the patient is we don't know if he's positive or negative. We can treat the patient as if he's positive, and we try if it's emergency. Now we are not doing any elective surgery. We do only emergency cases, so we try to use the masks. The N95, I think it's appropriate, and we after surgery, the problem is after surgery, to be sure that the patient is not positive. We do the test and we try to separate the patient if it's the problem is with the patients with tumor with the tumor, high risky to get the disease. So we have to keep this in mind and more protection maybe, and because there are patients at risk.
Great, thank you. And Gabriel, there's a question here regarding outpatients. At what stage of the pandemic can we see our patients in the outpatient clinic, and what type of specific precautions apply? So when will you start seeing outpatient patients, and are you going to take precautions and wear protective gear?
Right. I think majority of the situation that when we restart is really depending on the hospital capability of dealing with the curve. Is if the curve is flattened, then the matches the hospital capability, then we can do more. While we're doing that, until we have the vaccine, and then we still have to play with this second wave attack, third wave attack, and fourth wave attack whenever it happens. So the system will probably changing quite dramatically. In regards to clinics-wise, most likely we will build on, as this previous speaker talked about, building on a lot of telemedicine capability, and then discussing them, and then probably they can come to the hospital to do the MRI, but the consultation may not necessarily be physical, maybe be online. And this is probably one of the things. And also testing, as previous speaker have talked about, is a key thing. While we don't have antibody testing at this point of time in Singapore, and then we're still relying on the swab test, and then and the specificity of the swab test often may not be as high as one. So at the moment we are still currently relying on the history taking, avoidance, as well as the if suspected, we probably do 2 swab tests within 24 hours break time to determine whether we have to deal with that case, whether it's positive or not positive. So these are some of the aspects that we are thinking of, and then when starting to see more of the clinics. Yeah, and also from previous speaker talks about, that probably will require the hospital system will probably develop into like a triage scoring system, for those cases that are more acute. For example, some of the, Dr. Chapman already mentioned about some of the criteria. For example, if you require day surgery, then maybe, you know, you are more prone towards that you can come to the hospital, or for people who require ICU stay, they probably would not. People who are discectomy, endoscopic surgery, they may be more prone for go. And then these are some of the criteria system. But these are mainly for the middle spectrum. So for example, you have basically a bell-shaped curve of all the cases. On one end of the bell shape is really all the emergency cases that you have to do, fracture, infection, cancer, and trauma. And then the other spectrum, those who are really severe neurological deficit and deformity, you have to do something. Majority of the patients are those one-level T-lifts or this and that. Then you need to, in order for the public to be able to be transparent to the public, because they would have a big uproar. I mean, how do you select which case to go? Is it because of private patient you will go for that, or the public patient you will not be able to? So probably a transparent system for scoring would be important. And one domain of that scoring system will probably require to talk about the hospital resources as opposed to the current disease severity system that we are using for example, deformity surgery, scoliosis surgery, and things like that.
Great, thank you. And Juan, question for you. Actually, there's kind of two. By what means are you mitigating outpatient staff and patient density in your surgical practice? So how are you trying to eliminate crowding of patients? And any advice about pediatric patients?
Yeah, thank you, Jeff. You know, thanks to God, at least here, people alone decide to don't come to the clinic. You know, we realize how many patients came for small symptoms, and right now they are paying a lot of attention. So that was a big change. We usually don't have too much crowds in the hospital. However, we decide to extend the hour of attentions, and usually we have doctors even 2 or 3 a.m. in the clinic, just to be sure that never we have too much doctors at the same time in the hospital. That allow to separate a little bit the opportunity to patients to come to doctors. And regarding the pediatric patients, I work in the morning in the hospital, in the big hospital here in Argentina for pediatric patients. And you know, the problems are not the patients, are the fathers especially. You know, the patients, at least until now in more of the countries, the pediatric patients don't have too much problems. Probably most of them course as asymptomatic. And the issue is with the fathers and the doctors. We are dealing with a lot of positive cases in pediatricians, because most of the patients remain asymptomatic. It's different with adults, that is much more easy. So with the pediatric patients, our big concern are not the patients by itself, but more the doctors and the family. That is the big challenge right now. And you know, we don't have the solutions. We take all the extra care possible, but probably because we are starting, that is our big concern. And Jeff, I take this opportunity because you have doctors with a lot of experience to ask a question, if it's possible. How are you dealing? Because we are starting to look for more and more doctors positive. Are you working in teams? If you want to give some advice about that, you work in teams, you go to different days to the hospitals, you are prepared to have, you know, like a protocol. If you can share something on that, will be amazing.
Sure. So real quickly, you know, everyone has different strategies. I think one of the strategies I heard, which is articulated best by Scott Bowden out of Emory, is dividing your staff into 2 teams. And each team work 14 days on, 14 days off. And so if one of them gets contaminated or gets the virus, there's 14 days for that to incubate and to show it. You make sure that socially as well as in the hospital, those teams don't interact with each other. So there's no cross talk. It's only by phone or by the internet. There's no personal interaction between the two. At our hospital, we're actually thinking about opening up one of our buildings, which has a whole OR in it, and having everyone tested and only have negative, kind of what they did in China, having a COVID negative building. And that means all the staff, nurses, cleaning crew, everyone that enters that building is negative. And so maybe we could do procedures more safely in that negative environment. but also when we start to implement, we're going to focus on the younger patients, lowest risk, outpatient surgeries, won't need an ICU bed, and the people that are at least risk, and get them out of the hospital so we don't take up the resources. With that, we're almost out of time, but I do want to ask one more question to Karsten. Karsten, we've talked a lot about surgical interventions, and a lot of the NAS membership are obviously interventionalists. Would you say that a lot of the things we've discussed about surgery, about patient protection, and about screening would apply to the non-operative interventional realm as far as outpatient procedures?
Well, regarding the interventional things, you can obviously try to help the patients through a postponed surgery scheduling. One issue we have is the use of cortisone, and increased risk of catching the virus and affecting the immune system. But there's a number of literature out there, and I haven't really got any clear guidance. Me, from my department, we decided not to use it at this point. And overall, we're doing a lot, doing about 10 to 20% of what we usually do in terms of caseload.
So with that, we're basically out of time. We went a little over time. I do want to thank the audience for tuning in. This will be recorded and available on the spine.org website, which is the NAS website. And again, I want to thank all the speakers, especially those internationally where it's in the middle of the night. I want to thank you for taking the time to attend this webinar. I want to thank all the speakers domestically, and I hope that everyone is safe and that we're hopefully back to normal at some point. With that, I'll go ahead and conclude the webinar and thank everyone. Take care.
Okay. Bye.
Bye. Thank you.
Bye-bye. Thank you, Jeff.
Thank you.